All right, let's get right into it. We are tackling one of the most critical decisions in all of medicine, knowing that exact moment when a patient needs to be put on a mechanical ventilator. Get it right, and you save a life. It's that serious.
And to guide us through this, we're going to be using the fantastic framework prepared by Dr. Suhail Khalid Abu Bakr. We're going to break down his expert approach step by step.
So this is the big question, isn't it? In the middle of a chaotic situation, with alarms going off and a patient clearly struggling, how do you cut through the noise and make a confident, life-saving call? Well, that's exactly what we're here to figure out.
So here's how we'll do it. First, we'll define the actual problem we're facing. Then, we'll talk about what you can see just by looking at the patient. We'll break down the different types of failure, dig into the root causes, then look at the hard data, and finally put it all together to answer the question, when do we intervene?
Okay, first things first. The whole reason we're even having this conversation is because of one condition, acute respiratory failure. You'll hear it called ARF.
So what exactly is ARF? Well, it's pretty simple at its core. It's when the lungs can no longer do their two main jobs, get oxygen in and get carbon dioxide out. When that fundamental gas exchange fails, the body's entire chemical balance, its pH, gets thrown way out of whack.
And that's where the ventilator comes in. And look, it's doing so much more than just breathing for the patient. We're trying to reverse the failure itself, calm their distress, and fix those dangerously low oxygen levels. We're also trying to keep parts of the lung from collapsing, and this is a big one. Give the patient's exhausted breathing muscles a much-needed break. Now, let's step away from the textbook and go to the bedside, because long before you see any numbers on a screen, the patient's body is telling you a story. You just have to know the language.
So your first assessment is this quick 3-part scan. Number 1, level of consciousness. Are they with you or are they confused and slipping away? Number 2, their skin. Are you seeing that bluish tint, cyanosis, or are they pale and sweating? Those are huge red flags. And 3, the vitals. A skyrocketing respiratory rate and heart rate are the body's first alarm bells.
Then you need to look closer for the signs of distress. I'm talking about the visible work of breathing. When you see someone using their neck and shoulder muscles just to take a breath, when their nostrils are flaring, when the skin between their ribs is getting sucked in, their body is screaming for help. And if you see paradoxical breathing, where the chest and belly are moving in opposite directions, that is a very, very ominous sign. The system is about to give out.
Okay, so we can see the patient is in distress. Now we need to get a little more specific. Generally speaking, respiratory failure comes in 2 main flavors. You've got hyposemic and hypercapnic failure. The easiest way to think about it is this. Hyposemic is an oxygenation problem. You can't get enough oxygen into the blood. Hypercapnic, on the other hand, is a ventilation problem. The pump, your diaphragm and chest muscles, is failing, and you can't get the carbon dioxide out. One starves your organs of oxygen, the other lets poison build up. Both are deadly.
So that raises a really important question. Why does the pump fail? If we can understand the why behind that ventilation problem, we can treat it way more effectively. And the causes are all over the map. It could be a problem with the body's command center, the brain, from something like a stroke or a drug overdose, or it could be an issue with the wiring, a neuromuscular disease that makes the muscles weak. And sometimes the pump is working just fine, but the job is just too hard, like in a massive asthma attack or a major chest injury.
Let's take that stroke patient, for example. The need for a breathing tube isn't just about breathing. It's also about the fact that they may not be able to protect their own airway from, say, aspirating. So in that case, intubation serves 2 critical jobs, ventilation and protection. Okay, so we've used our eyes, we understand the potential causes, now it's time to bring in the hard data. Let's put some numbers to this crisis. This is a big one. It represents the PaCO2, or the amount of carbon dioxide in the arterial blood. When that number climbs past 55 and just keeps on rising, that is a classic textbook sign of acute ventilatory failure. And here are the other numbers that should be setting off alarm bells. A pH dropping below 7.25 means the blood is becoming dangerously acidic. A PaO2-FiO2 ratio under 200 tells you there's a major problem with getting oxygen into the body. And things like vital capacity and max inspiratory pressure, they're not just numbers. They are direct measurements of how much gas is left in the tank for the breathing muscles. And this is so powerful. Think about a patient with a disease like Guillain-Barré, where we know their muscles are getting progressively weaker. By tracking their MIP and vital capacity, we can literally watch their strength decline in real time. It lets us step in and help them before they completely collapse. It's proactive, not reactive.
All right, we've looked at the patient, we've looked at the labs, we've understood the mechanics. It's time to bring it all home and make the final call.
And I want you to really let this sink in because it is probably the most important thing we'll talk about. There is no magic number. No single lab value screams intubate. A patient is not their PaCO2. The decision is so much bigger than that.
It's a synthesis. It's about putting all the puzzle pieces together. You take their history, what you're seeing with your own eyes, what the blood gas is telling you, the lung measurements, and, just as important, you consider the patient's overall prognosis and, whenever possible, their own wishes. You have to see the entire clinical picture.
So, in the end, it really is both an art and a science. You're combining the hard data and the physiology with your own clinical judgment and experience. You're weighing all the evidence to make the right call for the right patient at the right time. The only question left is, are you ready to make it?